Good morning, good evening, wherever you are, good afternoon, wherever you are. Welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel. I'm the host of the show. I also want to welcome any viewers that watch this on replay or that are watching this on replay. I know we always get a lot of views on replay as well. Today we're going to focus on questions from families in intensive care or any families that have an interest in intensive care at home. Before we dive into today's questions, what makes me qualified to host a show like this? What makes me qualified is I'm a critical care nurse of over 25 years, having worked in critical care nursing in 3 different countries for over 25 years, and I've worked as a nurse manager in intensive care for over 5 years, and I've been consulting and advocating in intensive care for families in intensive care all around the world for over since 2013 here at intensivecarehotline.com. Darren, I can see you and I'll let you in 1 second. All right, just let me do the intro and then I will get you on this call. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are sending our critical care nurses into the home 24 hours a day for long-term ventilation, tracheostomy, and we are providing a genuine alternative to a long-term stay in intensive care. And we are providing this service all around Australia. Now, if you like the work that I'm doing here, I appreciate if you can like the video, subscribe to my YouTube channel, and share the video with your friends and families, and comment what you want to see, what your interest is. Darren, I will let you in. Can you hear me, Darren?
Yes, I can. Yeah,
that's wonderful. Darren, how can I help you?
Well, we just signed up for the email service.
Oh, okay. Yes. Okay. So Christina.
Yes,
Christine.
that's correct.
Christine. Okay, got it.
Christine
yes,
with a K.
yes,
That's right. Correct.
Yes. Mm-hmm. Okay, got it. Okay, now. Well, thank you so much for joining.
Mm-hmm. Yes. No, glad to have a resource at this time because it's very confusing, and we've seen a lot of the stuff that probably a lot of people just stumble upon, and I think it's put there on purpose.
Absolutely.
Mm-hmm.
What are your specific questions?
For today, I wanted to know if you've dealt with somebody that's had a hard time pulling IV lines and stuff like that, because the person I'm talking about has finally been off of without the mittens for a few days, and it's had some good days, but has been lying on his back for 70 days on a ventilator. Yep. 70, you know what I mean? That's a long time. And these were the first 4 days with his mittens off, where we feel like we've got medications balanced, where he's not anxious or whatever, and able to, sit upright with a physical therapist and all that stuff. Although we have been sitting him up in bed since you told us mobility is the best thing for recovery. So we've been trying to do that daily. And then he just sat up recently, and what are we going to do about these mittens if they keep becoming an issue?
And I also know from the notes that he self-extubated multiple times. So it is a real risk. And given that he's self-extubated, he's probably also at risk of pulling out the tracheostomy.
Yes, he has done.
Okay.
He pulled the trach once, self-extubated, and pulled the tracheostomy tube once.
Right. Okay. So let me ask you this. Do you think that he's confused?
Do we think he is confused?
Yes.
So it's times he will be 100% lucid, but it seems like a lot of times he'll forget previous conversations, and it depends on what medication they have him on, because you know what I mean, they've got him on some heavy duty medications, and a lot of times by the time they get the medications that they're using to get him under control, he's out, you know what I mean? So it's a balance, I guess, a little bit, just to keep him, you know, alert and awake enough, but also not getting anxious enough where he, you know what I mean, starts being a danger to himself.
Would you suggest he is anxious?
I think at times, yeah.
I think at times, yes. I mean, I would have to imagine being in that bed for 70 days. I know I would be anxious.
Very much so. Very much so. I'm just obviously having his medications in front of me. He's still on Precedex for delirium.
Precedex?
Okay. Precedex, also known as dexmedetomidine.
Okay.
Is that 10x?
Okay, go ahead.
It's a sedative. It's a mild sedative.
Mm-hmm.
I am wondering what will happen if they take that off. Would they need to potentially replace that with something else?
Yes, I believe so.
The other question that I'm having is he in a day and night rhythm? Is he sleeping at night and is he awake during the day?
I think that depends, and they're giving him the Zyprexa 5 milligrams at night, and that's helping him sleep at night. Yes,
that's helping him.
Yeah,
okay.
And then they're giving him 2.5 milligrams of it in the morning.
Right.
And then more if needed, but if it's a good day, it's pretty much that will be a good dose for him to be up and talking to us and active and helpful to himself and everything. Okay. It's just when he seems like when he needs more than that, you know what I mean? It gets things turned bad quickly.
I can also see that he's on melatonin, 9 milligrams.
Mm-hmm.
Do you know what melatonin is?
Melatonin, I believe, is the one that helps you sleep, right?
Yeah, it's a natural product.
Yeah. Mm-hmm.
Not a chemical. It's a natural product.
Yeah, that your body makes melatonin, correct? Yes.
Say again?
Doesn't your body make melatonin?
Yeah.
Mm-hmm.
But because, James wouldn't have seen any natural daylight for 70 days now, would that be fair to say?
I don't know, because the sun's actually been really bright in there and in his room, and it's actually I put the shades down to keep it cool.
Okay, so he does have a room with a window.
Yes.
Okay, that's at least something. Okay. What's happening in terms of mobilization?
So since we talked to you like last Friday or whatever, we've been having him sit up, and we've been telling him if he wants to get off the ventilator, that you said a couple of things were going to happen: mobilization and weaning, an actual plan to wean him down off of the ventilator. So we went with that, and we've been active. And when he's good, like he's been having problems with itching too. That's part of the reason why he's pulling IVs and stuff, because stuff is itching so badly. But he'll sit up bolt right in bed, and I'll just scratch his back like all the way up in bed and just sit by himself, like I'm moving the ventilator tubing with him and stuff, you know what I mean? And he'll be very active and normal, you know what I mean? So it seems like to me.
Right. Okay. But no one has sat him in a chair in a recline, and that hasn't happened yet, has it?
No, just the actual, because of the mittens, again, the last 4 days being the days that he had the mittens off 24 hours a day. So the day before yesterday, he sat upright in bed with a physical therapist, the respiratory therapist, and 2 other helpers to help him sit upright in bed and do it slowly and do everything. And he sat for 14 minutes the first day. which was the day before yesterday. And then yesterday he sat for 8 minutes total. Like he sat for 3, he didn't want to do it. Christine was able to make it down there when, you know, we were busy. We made it down there and he did it for another 5 minutes.
Mm-hmm.
Okay. So more or less 5 minutes has been the starting point.
Yeah. Mm-hmm.
Okay. But that is the starting point, you know.
Yes.
If they can extend that to 10 minutes tomorrow, to 15 minutes the next day, and so forth,
Yes.
you know, that would be really good.
Yeah.
What I can see from his notes, Darren and Christine, is, you know, he's stable. As far as I can see, he's stable,
Mm-hmm.
which means, you know, getting him out of bed should be a matter of time. Obviously, you know, they need to increase his exercise daily, right? Also, another thing, has he, and you know, you might think that's not possible, but I believe it is possible. Has he had a shower yet?
No.
No.
So a good ICU will take a patient on a shower trolley and give them a shower. Now, I can tell you that works wonders.
I know they work wonders for me.
Yeah,
I
that's really good.
I
I
guess
know they work wonders for me. I've got a goal now. We've been
Right.
bathing his hair with the little shower cap things and
Sure.
shaving him and stuff to make him feel better. Yeah, I'll bet you the shower would.
I'm not the doctor.
I argue, Darren and Christine, not giving him a shower, not sitting him out of bed, it's complacency. It's not a case of not being able to do it. It's a matter of complacency. If there's a will, there's a way.
Mm-hmm. Mm-hmm. And we've been going down there every day, like literally, especially right now, because we got the doctor to assign physical therapy for a couple of weeks. So those people are going to come back Monday through Friday every day and try and get him to work. So I want to be very
doctors
very like in the mix daily for the next, you know, couple weeks.
Absolutely. And don't get me wrong, because I know his notes, you know, he's got a weak heart, you know, he's got heart failure. But how will you build up that tolerance you're not building up that tolerance by just keeping him in bed.
Mm-hmm.
You're not.
So the ejection factor they were talking about, he was like at 40, right around the 45 before. Now it's gone down to 40. Is that right?
It has reduced slightly, has it?
That's what I was asking you, because before
I can see in the notes 40 to 45%.
40 to 45, yeah, which is mildly depressed, correct? Right?
Mildly. There's patients with 30 and less.
Yes.
Right. I argue the 40 to 45% will not stop him from getting mobilized.
Okay, good.
But then
Good.
the doctor doesn't want to.
Right.
Yeah. Yeah. Oh, yeah. And so the doctor now, the change of doctors too with the facility we have, it's a regular change and it's week change. And this one just called out. Boop. We just got the doctor that he had last week, who was a brand new guy who basically was following the direction of his previous doctor, who had kind of been railroading us for a while and keeping us out of the mix because they had already written him off. You know, so we're dealing with that, and he still believes that he's unweanable, although the pulmonologist last week said that yes, if he's getting better with mittens off and he's doing better and we can get a plan for mobilization, then yes, we can work more on getting him off of the ventilator.
Right. I think, you know, what I just mentioned, whether it's, you know, giving him a shower, whether it's getting him out of bed, the most important thing is get him back to as much normality as possible. You know, I mean, his circumstances are not normal.
No.
They are normal for patients in ICU, unfortunately, that's the reality, but he needs to get back to normality as quickly as possible, which once again includes, you know, having a shower, getting him out of bed, you know, trying to get him as strong as possible. And that will take time. But if they're not starting, you know, and if they're not increasing his exercise tolerance step by step, it'll be very difficult for him to get back to baseline eventually. You know, when I look at his ventilator settings, he's got a long way to go there, no question. But he will only be able to wean off the ventilator if he can sit up, his breathing muscles will get stronger. Just by someone sitting up, their breathing muscles and their muscle tones in general are getting stronger, because he would be so deconditioned after 70 days in ICU.
Yeah. So yeah. So
Is,
yeah. That's.
is he getting, from your perspective, is he getting enough nutrition? Is he losing weight? Is he gaining weight?
I think he's stabilized. I think he's getting enough nutrition, but I'll take a look at that. True, and he's been having a lot of problems too with the bowel movements and stuff. And his diet, I think he was malnutritious when he came in. I think his diet was really bad. And they've been working on it, and he's been having problems with the stools. And one night when they were doing a thoracentesis on him, they gave him pain medicine, and this was on the 7th floor in the palliative care floor, more extended care floor, right? And he's pressure, they couldn't keep it up, and they rushed him down to the ER, that ICU, I mean, and all they gave him was Narcan. He stabilized by himself. Pressures were fine. The next day, he was off the ventilator for 3.5 hours.
Wow.
And he had a bowel movement that night. I swear to God, at the midnight that night, we rushed over. At midnight that night, he had a bowel movement. All of a sudden, became lucid again. Everything was good. And the next day, the respiratory therapist took him off the respirator for 3.5 hours. That was I don't know what happened. And his percentages haven't always high at 40. They've been 30. You know what I mean? But now it's and they had him on spontaneous before now, and now they're not because he's had setbacks and stuff. But yeah, I would like.
How long ago was that when he was off the ventilator for 3.5 hours? How long ago?
It was like April 15th, mid-April.
Mid-April. Couple weeks.
Right. Okay. And obviously, he hasn't been as good ever since.
No, correct. Not that good. No, they keep trying to wean him, and they keep saying his the carbon dioxide, what is it? The CO2, goes up, and that's is that capnography? Is that right? Yeah.
The capnography,
capnography. Yes, they're saying goes too high, and I haven't seen that. That's the only one I haven't been able to actually see on the ventilators or anywhere else. The capnography numbers.
And they're not. I can see in the notes they're not checking any arterial blood gases anymore, which is where they would get a high carbon dioxide from.
And that's where they would get them from. You have to check the blood gas, and they're not doing that test anymore.
That's right.
So we need to get them. Okay, perfect.
They can do the test from a venous. So there's 2 types of blood gases. One is an arterial blood gas, which he won't have anymore. But he could also have a venous blood gas. They could just run a blood gas from one of the bloods they're taking once a day. It's not quite as accurate as an arterial blood gas for the CO2, but it would still give them an indication
of where it's at. Maybe that's where they're taking it from and saying that he's not tolerating it. But so how would they do it because they're saying that he gets buildup if they start reducing the percentage and stuff? Wouldn't that take a while to happen?
No, it can happen pretty quickly.
Okay.
They might get it from the monitor, so they might have a capnograph in the ventilator circuit. They might.
Yeah. I'm going to ask him next time I'm there.
Right. Send us a picture of.
Yeah.
Would be good if you can send us a picture of the ventilator and the bedside monitor.
Yeah.
Would be really good.
Yep.
They might have a capnograph in the ventilator, but again, they would still need to verify those numbers with the blood test.
With the blood gas, okay.
It would
either
just be
arterial or venous, yes.
Because I can see in the report PCO2 is going up to 80 apparently, but where do those numbers come from? It's not clear where the numbers are coming from. Is that from a capnograph on the ventilator, or is it actually from an arterial or a venous blood gas? It's not clear.
Okay, that'll be
the other. So here's another thing. Let's just say he has high CO2. That's where some of the confusion might be coming from for him as well. So if CO2 goes up and it's not managed, patients can get delirious, patients can become confused.
Oh, okay.
right? So that might all contribute. Having said that, from what we are seeing, his ventilator settings are pretty high, which means he's on a lot of support.
Yeah, that, yes, we were wanted to see it 40. We were always trying to keep it at 30, or you know what I mean, and and hopefully get it down to 20, which is room air, right? So
21.
20, yeah,
But
yeah.
it's but when I'm saying he's on high levels of support, he's on 22 of pressure control, which is a lot.
Yeah, as
So
well, the pressure and he's not on spontaneous. It's set for 20 breaths a minute.
very much
When
so.
I can see when he's breathing at 23, but the machine's still doing the work because it has all the pressure behind it and everything else, right? Yeah,
Very much so.
yes.
Very much so. The other thing that I'm wondering, what's his weight approximately? Do you know his weight approximately?
I remember seeing
Usually
some.
135.
Okay, so that's right up the alley of 67 kilograms. Is that about 135
Yeah.
pounds? Is that what he was before?
That's what he was before. 130. Yes.
Okay.
And now?
Not sure. He's very thin, like his spines, you know what I mean, sticking out and stuff. Yeah.
Oh my goodness. Would you say he's less than 120 pounds?
I'll have, you know what? I know he probably is. Yes, I would say he's less than 120 probably.
Okay. The reason, okay, let's just say for simplicity is 120 pounds or even 130. The reason I'm asking is his tidal volume is 376 mils, which means that's the volume he's taking when he's breathing.
Uh-huh.
Literature and research suggests that tidal volume should be 7 to 10 mils per kilo. So let's just say he's 60 kilo, which is roughly 120, 125 pounds, right? 60 kilos times 7 would be conservative. That's 420 mils. His tidal volume is 376 mils. So could be a little bit better even with all the support that he's on.
Okay, so what if he was only weighing 105 pounds or 100, let's say 100 pounds?
Yeah, that would be, then his tidal volumes would be adequate.
Would be adequate. Okay.
Yeah,
all right. So that's important. Okay.
It is important. It is important. Look, really, in a situation like that, I do believe everything is important. You know, whether it's the mobilization, whether it's sleeping well at night, being awake during the day, nutrition, right? He can't eat, but that's why it's even more important that he's getting adequate nutrition, right? Does he have a nasogastric tube or does he have a PEG tube?
He has a GI tube.
GI tube.
Yeah.
Okay. Ask them if he's getting enough nutrition. If he's skin and bones, because that's what I'm hearing, then he's probably not getting adequate nutrition.
Okay. So, okay.
Right. Again, there's enough research out there that feeding and proper nutrition is very important in the recovery process.
With everything, right?
With everything.
Of course, it's probably even more important with recovery then.
Even more important. You know, it makes me extremely worried that you're saying he's skin and bones. You know, and think about it. He's not, you know, he's resting all day. So if he's resting all day and he's skin and bones and he's losing weight,
and how are we going to mobilize him if he doesn't have the calories?
How are we going to mobilize him if we're not going to give him adequate nutrition? Right. But here is the next question then. Is he digesting his feeds? Are they checking that? So what that looks like is every 4 hours, they should be checking residuals in his stomach. So what that means is every 4 hours, they should briefly stop the feeds. And they should be taking a syringe and see how much is coming out of the PEG tube, making sure he's actually absorbing and digesting. What if all of a sudden, you know, they could take out a liter of feeds that have not been absorbed?
Oh, yes. Okay.
Right.
Yeah.
So, you know, the devil is absolutely in the detail in a situation like that. You know, so many things need to be monitored. to make sure this is all going in the right direction.
Yeah, that would make sense too if he was having problems with the stools, to check that. Yeah.
Very much so. So let's just say he's having problems digesting and he's having problems opening bowels. So, you know, the next risk that comes out of that is if he's over full, but he's losing weight, right? He's at aspiration risk. He's at risk of vomiting, if that makes sense.
Mhm.
Right?
Yeah.
It's, you can see it's everything needs to be fine-tuned.
Interconnected and yes, very complicated.
Interconnected
Mm-hmm.
and fine-tuned.
Mm-hmm.
Right? Do you know how many meals an hour he's getting for peg tube feeds?
I read it in those notes, but
I can probably read it in
the
notes.
I be reference for that to know what's normal. Yeah, I think it's 4. He gets fed 4 times a day.
Mm-hmm.
So it's not continuous, actually, is it?
No.
I see. He's getting bolus feeds.
Yeah.
Okay.
Yes.
Yeah.
Yes.
Okay, which makes it also more likely that by the time they are giving him the bolus feeds, it makes it more likely that they're actually checking whether he's absorbing or not.
Yeah. Well, they are checking his blood afterward. Like they said, they had to change his, I think it was his magnesium or something was high, or something other, some other metal was high. Yes. And they had to make some adjustments and stuff. So they are checking. I know.
Okay, good. But clearly, if he's losing weight and he's skin and bones,
he needs more calories.
Something's not working.
Yeah. Okay.
Right. And this is why it keeps coming back to what I said in the beginning, that the sooner he can go back to some sort of normality, the better. You know, he's not in a normal state by any means.
No.
Right.
No.
And you know, he would be traumatized from all this time in bed, from all this time in ICU, being critically ill. You know, the sooner some normality can be implemented, like I said, whether that's with nutrition, whether that's with a shower, whether that's with getting out of bed, you know, I do believe it's also a self-fulfilling positive prophecy that he can get better if the right levels of care are implemented step by step. Now, I'm not expecting any quick wins
with him, no.
With him, but the process needs to be started.
Yep. Yep.
You know,
sooner rather than later. Yes.
Sooner rather than later.
Yeah.
Are they giving him physical therapy? Are the physical therapists coming around, move his arms, move his legs? Are they doing at least that?
No, that hasn't been happening, but we've been going there, and he's actually been pretty active himself, even in restraints.
Okay.
But no, not regularly. No, and those 2 weeks of physical therapy literally became because of our request to the doctor that he had last week. That was literally in the notes that it was at here. He told us that was at our request, and she's going to be going there for this week and hopefully all of next, and hopefully a little bit of the following week.
Yeah, good.
And it's 4 of them because he's on the ventilator, so it's a lot, you know.
Right, right. What are they saying? Are they saying anything in particular about the lung scarring? Are they talking about that?
Well, you know, again, it goes back and forth, and again, doctors come and go. I think they change. The doctors change. I think that the pulmonologist before said that he was unweanable, and then, you know, again, last week when we get a doctor when he's doing well and we start mobilizing him and he's sitting up in bed looking at the doctor, talking to him, the doctor's like, "Oh, okay, well, maybe he is weanable," and he talks to the pulmonologist. The pulmonologist says, "Yes, maybe he is weanable now, but it's not going to be a long recovery." So they agreed to that. And then we got a doctor swap again. And this one's saying he's not going to say anything about him being weanable. They have a meeting every Wednesday yet, you know what I mean? Until like next Wednesday, like you said. So that's what you were thinking. He's going to be there next Wednesday too.
He just wants to go to telling me to go to palliative again.
Yeah. Yeah. The doctor is sending us to the palliative care.
What are your thoughts around that? Do you know what?
I think he would get less than he is getting right now. from what I've seen. And you know what I mean? Like, he's not going to be getting 4 people in this room for physical therapy, I don't think, unless we continue to ask for it and he shows improvement. You know what I mean? Maybe they can keep doing it. You know what I mean? I'm hoping
Palliative.
in palliative. I don't know.
Do you know what palliative care means?
No. So I'm guessing the answer now is going to be no, because I don't want comfort measures until he dies.
That palliative care, look, palliative care can be symptom management for pain, but more often than not, it's a euphemism for end of life care.
Okay.
Yeah.
So my question,
we don't need to talk to them yet.
Again, what narrative do you want to create? Do you want to create a narrative of palliative care? Do you want to create a narrative of recovery and, doing all the things that
are possible?
And, if they're not possible, yes, but you need to find out sooner than later if they're possible or not possible.
Mm-hmm.
And if you're going down the track of palliative care, you'll never find out.
Yeah. Okay. Thank you for that.
That's what they want. Yeah.
That's what they want.
They
Yes,
keep
we heard.
pushing that.
We heard the same theory, or the same I want a script. There you go. That's the word. We heard the same script from different doctors from palliative care. About what kind of life is that? What do you want for him to the getting the do not defibrillate in order before he goes to have a chest tube or the stoma in place. You know what I mean? A lot of stuff. And we heard the same thing from different doctors. And that tells me that they weren't really looking after his care. They were just placing him in a category that they're easier for them to write him off, in my mind.
Yeah. So they're creating the doom and gloom narrative.
Yes.
Yes.
Yeah. Okay. Well, isn't James awake?
Yes.
Why don't they ask him whether he wants to die or not? I mean,
I do, and he says no, and that's why we're fighting.
Well, he said the doctors.
But they don't have the guts to talk to him directly, do they?
No. No, they don't.
They have my sister because she was following.
Yeah,
everything
we had a bad sister involved. That yeah.
I just took over April 16th.
Yeah.
So.
Well, I mean, if they were taking their profession seriously, as far as I'm concerned, they would talk to him and ask him, what do you want us to do? Do you want us to help you get better, or do you want to die? It sounds to me like the answer is clear.
Yes, very. Otherwise, I wouldn't be wasting my time. I told him, when you don't want to quit fighting, you let me know. And he told me he would.
Yeah, that's unbelievable. Well,
I've had conversations with him.
Yeah, unbelievable that they don't have the guts
to talk
to him.
Yeah, right. Because he's his own decision maker.
I don't believe, I can't. Yeah, but unfortunately, I've seen it over and over again.
Yeah.
Unfortunately,
yes.
Like,
yeah.
Okay. Well, then it's crystal clear what he wants, and then it's also crystal clear that, yeah, he shouldn't, or you shouldn't entertain talking to palliative care. You should be talking to rehab physicians and how can we improve his situation.
Mm-hmm.
It's unfortunately, this is going to be a long game, I believe, in terms of, like I said, sit him up for 5 minutes today, sit him up for 10 minutes tomorrow, 15 minutes the next day. Maybe then increase that to once in the morning, once in the afternoon, until he's ready to get in a chair. Now, he might be ready to get in a chair tomorrow. I don't know. That's what the physios need to find out, the nurses, the doctors, they need to work on a plan to improve his situation.
Go ahead. How do we get that? Because they don't want to do that.
Okay. Have you had any, how do you communicate with them? Are you just sort of informally communicating?
We're there. We've been going to the hospital every day, every single day.
He just called me, the new doctor.
Okay. So if you weren't advocating for him, they would basically go down the track of palliative care. That would be,
yes,
that's obvious.
Mm-hmm.
Yes.
Okay. All right. Who's the decision maker there, you think?
I am Christine.
No. I know. No, I mean
Oh, at the hospital.
from the hospital. Who do you think is sort of driving all of this?
Whichever doctor is his assigned doctor for that floor for that week.
Okay. Oh, okay. I see.
They have a meeting every Wednesday.
And they change doctors.
And they change
Every
doctors
Wednesday.
every Tuesday. They have a meeting every Wednesday. He has a meeting every Wednesday with 5 doctors, with a pulmonologist, with a physical therapist, with the psychologist, with his regular doctor, and somebody else, probably a hospitalist of house.
Right. What's the physical therapist saying in particular? Have you spoken to the sort of the physical therapist then?
She called me yesterday and asked me if I could get down there because his appointment was at 3:15 that day, and they couldn't delay much longer, but that he was being restless. So luckily, Christine was already on her way down there. I actually was at a doctor's appointment and ran down there directly after and saw him finishing up. But that's only the second day she's been able to work with him. She wants to work with him, but she's only been given a couple weeks, I think.
Mm-hmm.
Okay. Oh, I see. So she's on a timer more or less.
Yes.
Okay. Look, I would do the following. If you think the message is not getting through,
Mm-hmm.
I would then escalate it to hospital executive. And I hear what you're saying in terms of that they are changing the doctor every week. But there must be like a medical director
Of the hospital, of Kaiser?
of the ICU.
Oh,
There
yes.
must be.
There's one of there's typically, I think, on each floor there's a director of the floor. Yes.
That is probably the main decision maker there.
Mm-hmm.
So where the team is speaking.
Okay, I got it. That's where the continuity is gonna come from.
Very much so.
Okay.
Have they not pushed you to send him to an LTAC? Do you know what I mean by that?
Long-term care facility. Well, he has restraints on, so they can't. Restraints and a ventilator, so they cannot.
Yeah, and I'm not, if you ask me, I wouldn't send him to an LTAC regardless, but I was wondering whether that they're potentially
they would love to transfer him out. And we keep saying yes, we would love that to happen too, because we don't want them to go a palliative care route.
Okay. When was the first time they mentioned it, that they would like to transfer him out?
That Dr. Lee talked about it because they were saying he was not weanable, but he can be transferred down to a long-term acute care facility, but not while he's in restraints. So they're trying to get the medications figured out so he wouldn't be snowed all the time. Well, guess what? We finally got his mittens off for a few days, which means they probably have been keeping him tranked on. I don't want to say that on purpose, but you know what I mean? But when they keep him snowed, he's not a pain in their butt.
Of course.
Well, yeah. The big problem, it seems like to me, Patrick, is that when they change doctors, it changes. Like we got one good doctor, Dr. Jorky, and he was really involved. And I saw him twice a day, and he spoke with me. And he's the one that ordered the physical therapy, and said he was winnable, but it'd be longer. But he was only there for a week, and that's when my brother started improving. Then he got this other doctor that came in on Tuesday, not too hands-on, came in, said his lungs were, listened to his lungs with the, what is it called? Stethoscope. Said the lungs were clear, but didn't really do anything. And then he called out today, and I got my brother, the old doctor that came in before that, the previous doctor, that was like totally pushing the palliative care and what I wanted to do and blah, blah, blah. But now it seems like he's going to go. He asked me if I saw him today, that he was not lucid, and that, I said, well, I figured it was going to be a bad day because he was so restless yesterday and active with physical therapy. But it just seems like things change depending on the doctor.
I see.
There's no consistency.
So here is what I would do if I was you then, to get more consistency and make sure they're all working towards the same goal. I would take this out of ICU and I would write to hospital executive, talking about the inconsistency, talking about how his wishes are being ignored, and that he has no interest in palliative care because he's of sound mind, clearly, from what I'm hearing from you. Or do you think they question that he's of sound mind?
I think they question that. They keep putting delirium in the notes. You know what I mean? But he'll sit there and talk to you. Although I have to say, I feel like his mentation is getting less. I have to be honest. Like he's forgetting daily, you know, conversations that we've had the day before. And I feel like his conversations are becoming less deep, about less important things, more like trivial little things.
Yeah. Yeah. How does he communicate? I mean, he can't talk, but he can mouth words, and
he can mouth words, and he uses his eyebrows, and he can write. He'll write. He wrote
I see. Okay,
pages.
right. Okay.
If we can, but we have to sit there and watch him.
Of course.
His mittens have to be off, and so for the last few days, yes, he's written pages and pages.
Okay, but that what he's writing makes sense.
Yes.
Okay. Okay. Well.
There you go.
Of course. Look, I can tell you from experience, most patients in ICU after 70 days would have some form of confusion.
Yeah. Yes.
Right?
Of course.
You know, they might be in ICU delirium, ICU psychosis, and they may not necessarily have a long-term brain damage. They're just going through that phase where, you know, if they keep
brain's
improving,
protecting itself.
That's right.
Yeah, their brain's protecting itself.
No, yeah, he had conversations with me like this last week. He was really good on.
We've talked with somebody
Monday and Tuesday.
We talked with somebody that had a 2-year recovery, and they don't remember the 2 years. Yep. It's blacked out. They remember bits and pieces of it only, and that's what I've been. Jimmy is to remember James Pope. Yes, he had a 2-year recovery. He does not remember it. You're probably not going to remember any of this.
Yeah. And I'm not surprised by any means to hear that. You know, like I've seen it over and over again that patients don't remember a single thing about their days, weeks, months in ICU. They don't. And some do. You know, but it's not a one size fits all.
Yeah.
And clearly, if they would ask him directly, hey, James, do you want to, you know, help us to improve, or do you want to die? The answer seems to be clear to me.
Yes.
And with that in mind, you know, I would, if you think you're not being heard by the ICU team, that then I do believe your next step is to escalate this to hospital executive.
I think that's a great idea. And I like talking to the floor supervisor first and escalating it that way and saying, this is what we wrote to see happen for him. And yes, he's not being heard, and this is what he wants. And you can talk to him personally and see if that's what he wants.
Exactly. And I think it all comes back to patient autonomy.
Yeah.
You know, I mean, it all comes back to patient autonomy, and he's extremely, extremely vulnerable. You know, if it wasn't for you,
right?
Oh my God! Yeah,
you know, they would have switched the lights off now.
Yes.
Oh yeah.
Yeah.
You know, and thank God the lights are still on.
Yeah.
But I do believe they can become brighter if they're doing all the right things.
Yeah. I'm going to check on the nutrition and the weight first, and then get the capnography visualized, and I'll get you a picture of the heart monitor and a ventilator.
And I can also tell you, Darren and Christine, you know, for them, he's a lot of work.
Yes.
Yes.
No question.
He wears us out, Patrick. He can wear us out. No doubt.
Question. This is hard work. There is no question about that. You know, and there are no shortcuts besides improving. You know, imagine if he can only improve 1% a day, that would be progress, but that would also take time.
Yep. Yes. And I mean, I've taken off work right now to see through this, and I'm really curious to see if this physical therapy and getting him upright and stuff, like you said, maybe get those tidal volumes up to a better ratio. And you know what I mean? The
best comparison that I always try to make is, you know, anyone that wants to run a marathon cannot run a marathon without training. Anyone that wants to get off a ventilator cannot get off that ventilator without taking measured steps and, you know, increasing their tolerance every day.
Just a little tiny bit.
Right.
Just a little tiny bit. Improving. Now, I can tell you that when looking through the notes, he probably does have one big challenge, which is the lung scarring, you know, because that means he lost
volume,
some elasticity and volumes in the lungs, right?
Yeah.
That definitely is a challenge. There's no question about that. But they haven't even tried yet, have they?
No.
Mm-mm, no.
No.
No, my
not really.
sister was letting him go down the other path, the palliative care path. And I just got that away from her, like literally 2 weeks ago.
And can she see why?
Well, she stopped coming to visit him now.
Right.
It was
Right.
it was a mess, Patrick. It added another layer to an already very difficult situation.
Of course, of course. It certainly doesn't help if there's conflict, you know, with families, how, you know, what they want. That certainly doesn't help, for sure.
No, it doesn't. She was planning his funeral, was what was happening.
Right. Right. So do you think mentally, you know, you mentioned you think he's a little bit confused, or, you know, keeps the communication surface level, which to a degree is also not surprising given sort of the situation he's in.
You know, he was able to tell us his email addresses and passwords and everything to get into all of his stuff. You know, so
he's confused. I feel like he's confused based on what medication they give him the night before. Like he got morphine today. We gave him
Why?
Yeah, because I don't even know why. Probably because he was so agitated yesterday, so they want to keep him quiet today.
See, the problem with morphine or fentanyl is they're classified as opiates, and opiates have respiratory depression as the main side effect. Right?
Right.
And whilst it's definitely helping with keeping patients calm, you know, it's still, if you want to wean someone off a ventilator, ideally stay clear of morphine and fentanyl, because once again, they have respiratory depression as the main side effect.
I feel like they don't want to wean him off. That's how I feel, Patrick.
Patrick, what about methadone or oxycodone?
Yeah.
He's getting 10 milligrams of methadone, and and because he's got cervical spine issues in the neck. He's had issues for a long time, but they've had when he at his house, he was, I think, heavy on them. I think that's part of what got him in the situation. Yeah.
I see. Once again, you know, one of the side effects there is, you know, shallow breathing often.
Yes.
The same with oxycodone. Oxycodone is basically morphine based. Right? How much oxycodone is he taking?
I think it's 5 milligrams.
5 milligrams, we think.
As needed.
Once a day?
As needed.
Probably more.
As needed.
Yeah.
How many would he take in a day?
Well, now I don't know, but before he probably was taking more than that.
Yeah, I think he was taking more.
Own.
Yeah. In the hospital now, they're probably taking one or one of those, and then along with other things too. The other sedatives that we took, the Zyprexa, 5 milligrams at night and 2.5 in the morning.
I can't. I'm just looking through the list again.
He's got a very high tolerance too.
I can see that.
Yes.
I can see that.
They gave him yesterday. What was the tranquilizer they gave him?
Oh yeah, yesterday it was so bad. They gave him like Zyprexa, then Haldol.
They also gave him Haldol on top of that. And we were there, and he still didn't heal.
He was still writing, doing all these things. Then he had physical therapy after that. And then the nurse was so tired out. I literally had to I gave her a break and like was, watching him the whole time. And then she said she called in to get him trazodone.
On top of that,
And
because
then Zyprexa and trazodone at night. And then I left and called and they said he still didn't get quiet down after taking all those medications.
Are you sure that he's right now still on the methadone? Are you sure about that?
I don't know.
I can look at his record.
Yeah. So am I. I can't see it in there. I can't see it in there.
Maybe they stopped it.
Which would be good. Which would be good if they did.
Okay. I know they've been trying to cut back. I mean, we've expressed our concern about that stuff. So they really tried to cut him back, but he was just getting so agitated that we've been trying to figure out how to calm him down so he's not his own worst agent of the recovery.
Yeah, he was doing good. A Dr. Yorkie was helping him that's the doctor that did really well and helped him. He actually was interested in helping and getting him better.
Yeah.
But he left.
They tried actually the respiratory therapist mentioned they should try changing out his seizure medication because maybe that was the one that was causing him the more agitation. And then when they did, he started to get her. Mm-hmm. So that may have been it. So he may just be that, we're doing physical therapy and he's just moving too fast and he's going to be up and down for a little bit. I don't know.
I feel like it was all the medicines yesterday caught up to him today when then they gave him morphine on top of it. That's what I feel like. And he was really tired.
Yeah.
Right. I can see that they've switched from Keppra to topiramate
for
anti-seizure.
Yeah.
But that was on the 24th of April, so that's been a while.
24th of April, but yes, the last week has been literally the last 4 days have only been the first 4 days that he's had his mittens off.
I see.
Mm-hmm.
The last week has been phenomenal.
Yeah, it was the best we had.
Okay.
Not as far as breathing, but as far as being a manageable patient.
And and
mentation and everything else.
Mm-hmm.
Yes.
Right. Look, I still come back to, getting back to quote unquote normality as much as possible.
Okay.
Making sure he can sleep at night. The ideal world is tiring him out during the day so that he can sleep at night, hopefully without too many medications.
Mm-hmm.
Right? So that they can hopefully avoid the Zyprexa.
Okay.
Yes. Get him tired out by the end of the day. Yes.
Tire him out during the day. Get him in a shower. Get him out of bed.
Get him in a chair.
Get him in a chair.
I don't want to do any of this.
All of that needs to happen. And I do believe that is the way forward here. And if he can't tolerate it, God forbid, fair enough. But they have to try.
At least we have to try, right?
Yeah, they're not
to try. Yeah. What is the nurse to patient ratio there? Is it a 2-to-1 or is it a 1-to-1? Does the nurse
it's not 1-to-1 because they always have other patients.
So the nurse is at least looking after one other patient. At least.
Yes. Mm-hmm.
Mm-hmm.
Okay, and they don't have any help from any nursing aides or
they do. They actually do have aides. Yes, and I've been helping a lot. To be honest with you.
Mm-hmm. We've been.
Yeah.
Right.
Except for when they brought, and then they also have a respiratory therapist that will come in. Like if his suctioning's not good enough, they'll call the respiratory therapist. They'll come down and they do treatments to them as well. He's getting the nebulizer, I think every 8 to 12 hours or something like that. And also, and they come in and check and suction him at a minimum every 4 hours, but he usually tells them more often.
Okay. And are they still restraining him on and off, or are the mittens and the restraints off completely now?
No, the restraints are on now. The mittens are off.
Mm-hmm.
Mittens are off. Okay. Have you actually checked that restraining a patient is legal? Have you checked that in your whereabouts are you again? You're in California?
Yes.
Yeah.
Have you actually checked whether that's legal? Because
I
I know in
believe
some.
I believe that it is, and to be honest with you, I believe that it is in his best interest and that he
Okay.
needs it
Okay.
to keep himself safe.
Yeah. No. That's okay. That's
He's
okay.
just
Yeah.
itchy.
Yeah. No, that's fair enough.
Mhm.
But you know,
And it was very
is-
bad at some point because he was pulling on him so hard when he was really confused and he didn't know what was going on. He was pulling on him so hard that he had bruising. It was terrible.
Yeah.
It was
Yeah.
very terrible. They're nice and loose now. We're talking. I take him off so he can write. You know what I mean? He lets me put him back on. You know what I mean?
I feel
So
like
it's
he's
better.
like strong, like because
He's very
been
strong.
through this, like because he's been through so many illnesses. Like if they would just try to wean him, I feel like he could do it. Because he even sits up and because my brother was in kinesiology, he knows a lot about medicine, so he knows these things, I think, and that's why he starts trying to move himself, like by himself, and sit up and
Just
put
sit
his
up in bed
legs
with
up
his
together,
ventilator. You know what I mean?
he puts it together like he's doing like a yoga pose almost, but he's not. I feel like we're not getting that cooperation from the staff. Like they're pushing, like because I
They're
just can't. Like I said, I just started being the active person in the family, but my sister was pushing was believing everything they said about
that there's no chance.
there's no chance, and he's
well,
literally sleeping every single day.
yeah. Look, I believe, you know, they need to give him a chance. That's part of the problem. They don't want to give him a chance.
Yeah.
No, they don't.
It's cheaper if they don't.
I feel that in my gut, my stomach, that's how they don't want to give him a chance.
Right. And you
Pushing
should trust that. You should trust that feeling, you know, that
Yeah.
this is what you're observing.
Yeah.
Mm-hmm.
Yeah.
And you should absolutely trust that. I would, if I was you, I would have a talk to them, to, you know, to the floor staff. But if you think this is not going anywhere, and bring it back to patient autonomy.
Okay.
This is what he wants.
This is what he wants, and he can clearly communicate that. And if you think that's not leading anywhere, then I would clearly escalate that to the top, like to a hospital executive, and make it very clear to them what you expect.
Okay. You know that.
Yeah. Okay.
And I wouldn't be shy about it.
Okay. Yep. No, there's no time for shyness right now.
There's no time for shyness.
No.
No, it took me so long to get my sister removed, and it came down to them asking him in front of us.
Yes.
Because they put her when we were on a conference call, and I wasn't able to make it in person. They went behind our backs and asked him when he was completely sedated, and he was saying yes to everything.
Even though we had more family members in favor of
Saying
Christine
me.
being the primary person, we were being railroaded by a doctor that had their ego bruised when we asked too many questions. She's labeled as the aggressive one. They wanted to they changed it over to the non-aggressive one. The only way she got it back was she went to the floor manager and said she wanted to speak to the manager because they broke HIPAA because she was first and they changed it and did it orally in front of him. And guess what? Finally, the doctors up that had been dodging us, we'd sit there for 3 hours a day in a row asking to talk to the doctor and she wouldn't come in. Finally, after Christine did that, the doctor came in, asked, and he got it changed. And so then we were back in charge of his care again. It was railroaded. But only because she decided to talk to the director of the floor.
That was after 2 months almost.
That was, yes, after 2 months. Horrible system.
Yeah.
Railroaded. We got, yep.
Frustrating.
Okay. All right. Look, Darren and Christine, I do need to wrap this up in a minute, really.
Okay.
Yes, of course. Mm-hmm.
But I think you've got enough takeaway points here, I would hope. You know what to do next. You know, talk to the floor. If you're not getting anywhere, let us know. We can help you with crafting a letter to hospital executive. We've written many letters or emails to hospital executive.
I'm sure.
Yes.
So, but you know, hopefully the floor will listen to you, and they need to talk to him.
Yeah.
They need to talk to James.
Yep. Yeah.
Okay.
You know, it's full steam ahead from here, I believe. Okay. Really nice to talk to you both. I do need to wrap this up here now.
Yep.
Okay,
Thank you so
thank
much,
you.
Patrick. We appreciate it.
Keep the questions coming.
Yes, we'll do.
And yes, if
We'll
we
do.
need
And I'll
more, we'll
get back to you pictures and the weight.
Yes, that would be good. That would be good.
Okay.
Thank you so much.
Yeah.
Thank
Thank you so much.
Thank you,
All right.
Patrick.
Thanks
Bye.
everyone for
Thank you.
watching. Thank you so much. Bye-bye.
Thank
Bye.
you.
Bye-bye.
Bye.
If you want consulting and advocacy, go to intensivecarehotline.com and I'll see you there. Or if you need intensive care at home services, go to intensivecareathome.com. Thank you so much for watching, and I'll see you again next week, same time, for another YouTube Live. And look out for my quick tips that are coming during the week. Take care for now, and thank you for your support. Like the video, subscribe to my YouTube channel, share the video with your friends and families, and comment below what you want to see next, what questions you have that I want to answer, that you want me to answer. Take care for now.